Our next speaker is Dr. Van Nostrand. Dr. Van Nostrand is the Director of Nuclear Medicine Research at MedStar Research Institute and MedStar Washington Hospital Center. He received his bachelor's degree from Duke University in 1969 and MD from Emory in 1973. He completed his residency in internal medicine at Wilford Hall Medical Center in 76 and his fellowship in nuclear medicine at the National Naval Medical Center 78. He's board certified in internal medicine and nuclear medicine. He was previously the director of nuclear medicine at MedStar Washington Hospital Center until 2015, at which point he directed on all his energy to research and became the director of nuclear medicine research at MedStar Health Research Institute, January 2016. He is a professor of medicine at Georgetown University. He's been actively involved in every aspect of thyroid cancer, from diagnosis to treatment, for over 40 years. He has published more than 200 articles, 10 books, including the third edition of more than 1,000 pages long medical textbook entitled Thyroid Cancer, A Comprehensive Guide to Clinical Management, which was co-edited by Dr. Bartofsky. Dr. Van Nostrand is a nationally and internationally renowned physician scientist with countless awards recognizing his contribution to thyroidology. Doug, we're very honored to have you.
Thank you. And can you hear me?
Excellent.
And can you see my slides?
Excellent.
Great. That completes my presentation.
That was short and sweet.
So thank you, Dr. Gulick, for the invitation. I'm honored that you asked me to speak. And you gave me the title that you see on this slide of Radioactive Iodine Imaging and Therapy in 2021. And I was supposed to bring together the previous talks by Victor Barnett and Marcus Lester and Ben Greenspan and et al. And others. And I sat there and I really did not know how to bring that all together in a 30-minute talk, other than to say things are controversial. And what I decided that I would like to do is to address a process, something a little bit different on controversies. And my subtitle, although it's not moving forward, my subtitle is Elephants Can't Play Basketball. Now, here are my disclosures. And as I did yesterday for my first talk, I'm including a new disclosure for PowerPoint. That's an excellent book out on slidology. And one of the main things they emphasize is rule number one, reduce verbiage, reduce verbiage, reduce verbiage, which I tried to do in the past, but I'm now violating rule one. And I'm not reducing verbiage because the slides, and I'm in webinars and virtual meetings of distributing my slides as typically PDF files. And then the reviewer of those slides don't have some of the verbiage that goes along with the slide. So anticipate that there will be more words. Now, after attending this presentation, an attendee will be encouraged to think differently. In fact, I was pleased, I think it was, I don't remember, but what probably was Marcus earlier talking about thinking differently. And over the last 2 decades, many physicians we really have been thinking differently. We're talking more about active surveillance for low-risk disease, less remnant ablation. Therapy diagnostic scans are not necessarily needed. Less is more, and that's a favorite, not in guidelines, but that's a favorite in many articles or presentations. We can treat it later. A patient is radioiodine refractory when the patient progresses after an I-131 therapy. Now, some of us will disagree some with some of these, and many of us will agree with some of these or all of these, but we all won't agree with all of these. And there's controversies. Now, whenever we have controversies regarding guidelines, we always say, this is our typical statement, but they're just guidelines, they're just statements. And in fact, they are just statements or guidelines, but it's also to point out that, and we have a wide spectrum of audiences here, but many of the practitioners, whether nuke med, endo, etc., often see these as definitions, strict sacrosanct guidelines, etc. So what I wanted to do is look at the process. The facts taken as I'm saying, for many physicians, or the guidelines are taken by many physicians as equivalent to facts because of various justification and benefits, such as, well, it's the literature, it's the guideline, it's expert opinion, it's a consensus. It's interesting, if you look up the word consensus in the Webster's New Dictionary, there's no consensus on the definition of consensus. These guidelines taken as facts, they simplify, they increase efficiency, they become essentially Betty Crocker cookbook recipes. And that's not a criticism, that's understandable. And they even allow, and this is not cynicism, but us to increase my RVUs and reduce my work because I've already have a guideline or a recipe of what to do. But what I'd like to do in this presentation is to do something a little bit different rather than summarizing what all the previous excellent presentations, and Marcus did a great job with many of the controversies. But I want to at least bring up an understanding of some of the limitations of the guidelines and our process, my process in looking at things. Let's analyze a statement or a guideline. Now, if this was a live performance or presentation in a auditorium, I'd take a show of hands, and we could do that with hands, but we're not going to do that here. But I think most of us would agree with a statement as a fact that elephants can't play basketball. And now let's take a look at this. Now, in defense of that statement, elephants can't play basketball, I'd be the first to say, well, this really isn't playing basketball. This is an elephant of a couple of 1,000 pounds jumping on a seesaw and pushing a guy up and stuffing it in the basket. So how about an alley-oop play? Well, I think the same argument could be presented. This isn't playing basketball. The operative word here is playing. That's not playing basketball. How about a shot outside the three-point line? For those who aren't basketball players, and I played a lot of basketball in my youth and up into college, but and we didn't even have three-point lines back then, but three-point line is a lot farther out, and thus you get 3 points for the shot if you make it instead of 2. So let's see if an elephant can do that. And here's a second shot. Now, that's pretty darn good. And one might say, yeah, but how long did it take the trainer to teach that elephant to make that three-point shot? Probably not as long as it took me to learn to do a three-point shot. It took me a long time before I could ever make those long shots like that. So how about one-on-one, elephant one-on-one with a human with a layup followed by a dunk shot? So a little hard to argue that elephants can't play basketball. But the guideline says that elephants can't play basketball. And so we hear in many of our conferences, when we're trying to individualize patient care, figure out what we think is best, but the guidelines don't say that. So what I'd like to do is go over some of the lessons that I hope came out from this little exercise, that it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. Guidelines are just guidelines. Second, what's interesting is, and I acted this out, but I'll show later, this is exactly what I would do and what we do as humans. We argue against the original statement or opinion or a guideline or a fact. Whatever we accept, we'll come out and say, well, you know, that's not playing basketball. The elephant didn't dribble. Second is we need to identify the key operative word. In case of elephants can't play basketball, the operative word is play. So that's where our controversies are. And let me pause for a moment and say controversies are good. And having differences of opinion and allowing those opinions allow us to see things differently and then to try to explore options to resolve those controversies. And one needs to identify then the limitations of the statement or the guideline and understand those. And one needs to think differently. So with this presentation, for the next decade, we've done a lot of thinking differently. I would like to propose that we continue to think differently and find the operative word within our controversies and try to air those out, allowing the various views, and think with the patient in mind. Now, as I'm going to expand on this a little bit, we may have exactly the same situation in two patients, and one patient might be interested in being very aggressive and another one being very non-aggressive. We'll talk about that more in a minute. Let's address these statements. From the standpoint of finding the operative word and thinking with the patient in mind, I'm not trying to go through and say active surveillance for low-risk disease isn't appropriate. I'm just going to be challenging these in order to say we have to think differently and keep the patient in mind. So what's the operative word in this? This is low. It's low-risk disease. Now, this is a slide which I unfortunately can't give credit to because I've forgotten who first developed it. But as one knows, in the ATA guidelines in 2009, the changes in Brian Haugen's excellent guidelines in 2015 was essentially to move this group over here. And that may be very reasonable. It's not my issue regarding that movement, but rather trying to look at various aspects of that. And what is the operative word low? So do we consider 1% low? We consider 8% low. It's very variable, and one needs to keep that in mind. Now, as an example, a personal example, some know I've had recent surgery, and I love to quote Mark Twain. Mark Twain said that his death had been very exaggerated. So I've done very well, and I'm glad I'm back on the circuit. But when I asked them what the mortality was on my surgery, they said, it's very low, 1%. And I said, that's low? So 1 to 2% are not going to come out of it. So it's the operative word of low. What is low? And how does not just the physician look at that or the literature look at that, but as we'll also discuss, how does the patient look at that? Now, there are many articles out there. Marcus showed an excellent slide of Dr. Verberg's manuscript of many of the articles. I've only picked a few just to challenge our thought process and to make us a couple of simple points, but not get into the controversy. This is an article from Dr. Verberg. This is where he administered 2,000 megabecquerels, which I believe is approximately 54 millicuries or more, and or administered less than 54 millicuries of activity. And this is specific survival in years. And these were low-risk patients, low being the operative word, with less than an age of 45. And those that got 54 or more millicuries did better than those who got less than 54. Just raising the question, we need to think about this. Now, this is a study by rule. In actual fact, in this study, they actually had the old criteria so that there's low risk. Now what's considered low risk is in the intermediate, but then raises issues that he was still able to show a difference. 21,000 patients, intermediate risk, as defined by the 2009 guidelines. The overall survival was significant, of less than 0.001, and I-131 was associated with a reduction in the risk of death of 29% in all patients. Again, intermediate mixed in there, but raises issues. And again, Marcus showed the nice slide from Dr. Verberg of all those articles that were reviewed. And 36 patients had a reduction in risk of death when they were younger than 45. Now, this slide is courtesy of Dr. Marcus, and of course it comes, as he showed in his presentation, from Anasaka in JCEM in 2004. And I will quickly go through this. As he pointed out, this is just pointing out that follow-up is important. The effectiveness on cancer mortality was only significant in one study. All the others are non-specific or not stated. And one would conclude or could quote any of these to say that I-131 isn't effective in altering mortality. But when one looks at the follow-up years, this is the longest follow-up of 16.6 years. Now, in regard to I-131 effectiveness, there were 4 that were significant. And when you look at follow-up, 16.6 years, 10.6 years, 11 years, 12 years. The emphasis being on that follow-up is important. And a lot of our articles, understandably, have 3-year follow-up, 6-year follow-up, 7-year follow-up. But it's important to think differently and to critically assess the information that we're trying to use for the patient. Duration of follow-up is frequently important in showing differences of therapies. So active surveillance for low-risk disease, I'm not opposed to that, but I want to think differently. What percent of recurrence is considered low? Not just for us, the physician, but for the patient. I have a different set of standards, possibly for my surgery or for therapy, and it may change depending upon what my problem is. Pre-therapy diagnostic scans are not necessarily needed. A lot of controversy about this, and I respect the controversies. Certainly I have my opinions, but that doesn't mean my opinion or approach is correct. So the operative word here is needed, necessarily needed. So let's take a look. Here's a pinhole image of the thyroid bed, chin marker, suprasternal notch marker, and there's nothing in it. Now, we performed a study early on in the late 2000s, and this occurred in 3% of patients, not a lot. I would not give a patient I-131 for this. I'd be reassessing, such as, did they go off their thyroid hormone? Did they have an iodine load, et cetera? And I won't go through that. This would alter my management. This is a pinhole image of the thyroid bed, 1, 2, 3, 4, 5, 6, 7. Dr. Kordjakar from our lab evaluated very select patient population with anything suggesting metastasis excluded that had normal ultrasounds. I won't go through all the criteria. What we learned is surgeons do not leave more than 4 foci typically. Very rare to have 1, 2, 3, 4, 5, 6, 7. This is strongly suggestive of metastatic disease in regional lymph nodes. This would stop my movement to do remnant ablation, and it would stop my movement to do active surveillance. I would want to reconsider ultrasound, want to look at what was done surgically. If I'm treating with I-131, I wouldn't be doing remnant ablation. I'd be at least doing adjuvant treatment. I may want them to do fine needle aspiration. It alters management. This is a pinhole image, pin marker, suprasternal marker. They're then removed, and then without moving the patient, I've taken a longer image. And this clearly suggests regional nodes in the right neck region, again, would alter my management. Now and all of these we have percent on how frequently these were seen. This was infrequently seen, and I certainly wouldn't do an I-131 therapy of any type. I'd be having a very courteousy conversation with our surgeon or endocrinologist regarding the surgical procedure. In this particular patient, there's bilateral lung activity and multiple focal areas of activity in the neck indicative of regional lymph node metastasis. This would certainly change my management. And this is a bone met. Again, not knowing this ahead of time, there was no indication. Admittedly, the patient did not have a CT of that area, but there were no symptoms in order to have a CT done. Now, in a previous study of 2009, the pre-therapy scans altered management in 29%. Again, I'm not saying one has to do the scans or has to mandatorily do the scans. What I'm doing is saying thinking differently. In regard to, and these were planar images, in regard to SPECT CT, Dr. Yu did a nice summary, and these articles are taken from his publication, and I've included one from Dr. Anka Avram, and we're seeing 22%, 29, 27, 20, 36% altering management. Another whole table from 22 to 41%. There was one that was reported that was 88%, but that sounded just a little too high even. So pre-therapy diagnostic scans are not necessarily needed. I don't disagree with that, but I think we need to think differently, and our pre-therapy, not post-therapy staging scans needed to stage some patients properly to decide whether to do active surveillance, I-131 therapy, the amount of administered activity or additional surgery, before we give them a blind empiric administration of I-131. Now, I've had a conversation with an individual, Elif Hindi, in Bordeaux, France, and there's major logistical issues regarding patients staying in for the scans, et cetera, healthcare coverage. So there are many, many factors that affect this. But the issue is to think differently. Less is more. Now, for those who haven't heard that, less means less activity is better because it gives you more in the sense that you have less side effects. So the operative word is more. Now, this is an article from Marie Castagno. This is an excellent article. She's an excellent researcher. She's actually a member from on our International Committee on Radioiodine Refractory Disease. And I've tabulated and distilled her tables for recurrent disease, biochemical, persistent disease, or death. And she compared 30 millicuries and 100 millicuries. So we're not now looking at remnant ablation, we're looking at intermediate disease and even some known metastasis. But when we look at these groups, 40%, it's not significant. There's no difference. 25 to 27, 28, no difference. 47, 40, not significant. 41 to 52 is also statistically not significant. And she's very smart, and she put her conclusion correct. Our study provides the first evidence that in patients at intermediate risk, high radioiodine activities have no major advantage over low activities. They don't have an advantage. I agree with that. Now, what concerns me, and again, trying to emphasize thinking differently, thinking about the elephant, is that there are at least 13 articles, I haven't looked since about 2 years ago, that have referenced Castagno's article, and they have taken the conclusion from that article that 30 millicuries is equally as effective as 100 millicuries. I would say, why couldn't one also interpret that just as well as they are equally ineffective as 100 millicuries? And that, in fact, one may need more I-131, not to say that 30 is fine instead of giving 100, that perhaps we need to think differently, that we need to give more than either 30 or 100. But 13 articles that I'm aware of have already referenced that. So less is more, we got to think differently. Less is more may mean more recurrence. Now, we can treat later. I fully admit that I do treat later, and to go to the extreme, I've had multiple pulmonary Mets. They were stable on CT. We followed them to see the character. The TG say the same. I have one individual who was in his late 70s that we followed for 8 years, and there was radioiodine uptake, and we did not treat until his TG pattern changed and his CT changed, and then we treated. But one really has to still say, really? We got to think about this before this is taken too seriously, that we can always treat later. I don't think the main fundamental is that we can treat metastasis later as easily as trying to prevent metastasis or eradicate metastasis in the very beginning. But I believe there are situations where it is appropriate. Can we treat it later? We need to think differently. Maybe we need to treat earlier, or what is the criteria for earlier versus later? Now, this is one of my favorite ones, and I fully admit I believe this, I supported this. And in the early 80s, a patient gets an I-131 therapy, progresses after the I-131 therapy, and that's a failure. We move on to something else. And of course, back in the 80s, we didn't have much else. And actually, this is in a guideline as saying that if they progress, they're radioiodine refractory. The operative word is progressive. And now this is the busy slide, which I will distill, and I apologize, but I included it so it would go out. This is an example of really looking at a patient and several issues to decide whether progression is significant or not. So a patient has no metastatic differentiated thyroid cancer, progresses and is progressing. And they get I-131 therapy and it progresses. Now, is that indicative that the patient's disease is radioiodine refractory? Should one treat the patient with an alternative treatment, such as TKI, or maybe understand the gene fusions and other things that Maria and Jim have discussed? What if I told you the patient was treated with 100 millicuries? What if I told you that prior to the present I-131 treatment, the patient's disease was progressing and the thyroid globulin was going up, but after the therapy, it's both stabilized for 14 months. In the first case, I would argue that this patient who's progressed after 100 doesn't have radioiodine refractory disease, but has, quite frankly and cynically, radioiodine refractory physician. This is not enough rads that's being given for the 100. Now, perhaps we can't get enough in, but this isn't enough. It couldn't be categorized as radioiodine refractory necessarily. Now, if this patient's progressing prior to the therapy and after the I-131 therapy, the patient has stable disease, didn't go away, didn't regress, but became stable for 14 months, why is that considered progression, that progression considered a failure? I would argue I just got 14 months for that patient, and we have these patients. Then I bought time for that patient. I'll consider another I-131 therapy, saving my lenvatinib or whatever drug one might use next. Classification of I-131 as a failure depends upon many factors, and I've not gone through all of these. This includes patient preparation, amount of millicuries administered, and most importantly, duration of progression-free survival. So think with the patient in mind. The operative word is progression. Think differently. In fact, many factors have to be considered that affect the classification of radioiodine refractory. Think differently about these. Instead of thinking of a Betty Crocker recipe, more for less, and why did I twist that? Because it's more RVUs for less work. And our staff are concerned about that, and the facilities that I visit, when there's an informal conversation, it almost always turns to RVUs. Increased efficiency, instead of thinking that, or simplification, they're all important. Expert opinion, consensus guidelines. Think with a patient in mind. Now, remember the elephant? Now, I'm sure you are like me, or I'm making that assumption. When I saw that and someone said elephants can't hula hoop, I would have said absolutely not, or I go, well, there's a catch here, so maybe they can. but the reality is we're prisoners of our own opinions, guidelines, statements, mantras, whatever. So think, what does the patient want? This is a book that Mike Tuttle first told me about at the Martinique Working Group in 2018 by Groupman and Hartspan. I immediately bought the book, and it discusses minimalists and maximalists. I highly recommend it to everyone, and I don't recommend it necessarily because you're a physician. I recommend it because the odds are you will be a patient. Think rad and not just millicuries, proper preparation, iodine diet, confirming low iodine diet, increased TSH, perhaps combination, maximizing I-131 activity for metastatic disease. My time is almost up and I'm almost completed. Think rad and not just millicuries, increasing uptake. The fantastic talks by Jim Fagan and Maria on redifferentiation and resensitization. About increasing retention, cold iodine loading after I-131. Lithium has been tried but not successful, same with diuretics. Thinking about scans, these two scans, same patient. This image shows a lot more. This image shows a lot more than this image. And certainly in this patient with the intensity higher, there's 1, 2, 3, 4, 5 areas. I would be thinking about altering my management. I'm going to step through that. Combination treatments should be strongly considered. This is a study by Wu Di, who looked at multiple modality approaches along with I-131, not just I-131 or not failure of I-131, but combinations. The black line represents I-131 combination treatments, and they had better survival than those that just got I-131 alone. Out of the box thinking. How's our time, Yuri?
Just you have maybe a couple more minutes and we'll have to wrap it up, please.
Okay, and I'm right at the end. So this is just to think out of the box. TG scan negative, positive scan negative. We do all the conventional imaging and they're all negative. How about a sestamibi scan? Sestamibis were used in the 80s and 90s. They're not great, but they were helpful until FDG PET put them out of business. But here's a patient with a sestamibi scan. I'll help you find the abnormality. There it is. If we look closely, there's a clear focal area with SPECT CT. There's one in the posterior occipital calvarium with a lytic lesion, and that was surgically proven as metastatic differentiated thyroid cancer. Consider blind I-131 therapies. And I'll show one more thing out of the box. This is a patient with a negative diagnostic scan, and we gave them 30 millicuries, and clearly there's a MET that was confirmed in the left humerus, and the patient was subsequently treated. We also did a 7-day scan, and there's multiple additional focal METs. This patient has a potential to have a response. Finally, we need to think about, and most importantly, benefits versus risk. So these are the things to think about that we reviewed. Individualize, 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 think differently, practice medicine, and think with the patient in mind. Now, this is a final video that I'd like to show you. This takes a minute, not a minute, but a little longer to load. This is a filming with Renee injured his leg. Now, remember the elephant. I fell into my own trap that I didn't figure out the operative word, and to think differently. I said, this has to be fudge. This has to be just training. But I'm not sure how you do that. And I decided it doesn't matter whether it's training or not. Certainly as humans, we learn to care and to help people who see danger. So we got to think differently, and we are prisoners of our own opinions that an elephant would never do this. We're prisoners of guidelines and statements. Think differently, think with the patient in mind. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. This is my staff, and they've really been wonderful to me because they help me think differently. And this is my present research staff. We have a lot of fun. My email is below there. You're welcome to email me, and I'll be happy to send out a PDF of the slides. Thank you very much. And back to you, Yuri.